Welcome everybody to the June edition of the trauma webinar series. This will be our last one before we take a break for summer, and we'll start back up in September. Today I'm joined with Adam Harris. He's the Medical Director of Education with Trauma Nova Scotia. He is so excited about this webinar that he wanted to introduce today's guest speaker himself. If anybody has any questions, just write them in the chat box. I'll ask all the questions at the end so we don't interrupt the flow of today's presentation, and we'll go from there. All right, Adam, take it away.
Well, thanks everyone for joining us today, and thank you for joining us over the last 6 months. The participation has been excellent. Today, I'm especially pleased to introduce a great friend and excellent colleague, Dr. John Armstrong. Dr. Armstrong is the medical director for special operations with EHS and is also the medical director for emergency preparedness through NS Health and Trauma Nova Scotia. Dr. Armstrong, in addition to completing his Royal College residency in emergency medicine, also completed a Master of Disaster Medicine in Italy. I affectionately refer to him as the Master of Disaster. So without further ado, I'd like to welcome Dr. Armstrong.
Hello, everybody. Thank you very much for having me here. I'm really excited to speak with you today, and thank you very much, Adam, for that very generous introduction. I'm here today to talk to you about mass casualty events in theory and practice, and how we can approach large numbers of very sick people in the best way to save the most number of lives that we can with the resources that may or may not be available. I have no conflict of interest. I do have an interest in conflict. Many, many years ago, my undergrad was in military and strategic studies at UNB. So that interest has kind of followed me through my career and led me to being, as Adam says, the Master of Disaster. So no academic or financial issues, however. This is our roadmap for today's talk. We're going to be talking first just about defining mass casualty events and how they're sort of described in the literature and what we need as healthcare providers to respond to them. I'll be talking about triage, both in the pre-hospital phase as well as within hospital reception. And then we're going to talk about secondary triage, which is a bit more of a philosophical conversation about when some people should not be getting the limited resources that we have if they're beyond repair. We're going to be talking about hospital reception of mass casualties and what I call empiric resuscitation, which is, as we'll get into later, a way to maximize what you can do in the least amount of time when you may not have the resources available to fully diagnose exactly what injuries you're working with, and then putting it all together. So the first section is going to be defining mass casualty. We're going to talk about the potential injury-causing event nomenclature, the critical substrates of receiving mass casualties, and the continuum of care during a patient surge and how that will affect us clinically and kind of psycho-emotionally. So mass casualty events really don't have a good definition. The literature really summarizes it as an event that overwhelms the available resources that you have. So in a pre-hospital situation with EHS, that would be a code red. And when those patients find their way to the hospital as an external disaster, that would be a Nova Scotia Health code orange. Often mass casualty events or disasters are defined as natural or man-made, with natural referring to something like a tornado or a hurricane, and man-made being bombs, bullets, and stuff like that. There has been a move to really say that most of these are partially man-made, as many natural disasters can be mitigated, and whether that's evacuating hurricane zones or having building codes that allow for earthquakes to happen without killing many people, there are a lot of things that humans can do to mitigate the quote-unquote natural disasters. All of these events are then medical or surgical. What we're going to be talking about today are surgical mass casualty events, which is really things that require surgeons as the definitive care. So penetrating and blunt traumas that have internal injuries that require surgical definitive care. Medical mass casualties are often chemical related, and whether that's an industrial accident or a more malicious terrorist attack or something like that, those would be a little bit more rare. So we're going to focus on the surgical mass casualty events today. This is the nomenclature used in the literature when talking about disasters. This is really not super helpful on the day. You won't find people scurrying around the emergency department, with the various prefixes for the PICE nomenclature at the tip of their tongue. But it is helpful to think about what types of disasters are out there and how it's going to impact the health system. So if you look at the prefixes A, B, and C, those are pretty self-explanatory. Something is either a static, over and done with incident, for example, a tornado or a single bomb explosion, or it's dynamic, something that is continuing to cause problems. This could be something like an insurrection. It could be something like major storm systems that are continuing to cause problems. And going into prefix B, we're looking at what that does to the system. Is it controllable? Is it disruptive? Or is it absolutely paralytic? So major snowstorms causing injuries, traffic accidents, carbon monoxide poisoning, and so on, could be paralytic to a system if no roads are open. And then prefix C looks at how widespread the disaster is and whether or not it's affecting just a local region or the entire world. So many people would say that the COVID pandemic was an international disruptive dynamic PICE. The projected need for outside aid goes from PICE stage 0 to 3, which looks at how much additional support any particular response will require and whether or not it needs to be alerted to be sent out or dispatched right away. So again, this is more for retrospective looks at disasters, but certainly the dynamic and static and controllable to paralytic are things that you should be thinking about when there's an event happening in your health system. So the critical substrates of disaster response are the classic S3, staff, supplies, and space, and more S4, adding in support. So staff, self-explanatory. This is all your clinical and supportive staff. You should also really think about your administration, and that comes in with support. Supplies are all the things you're going to need. And when you look at your own hospital, your own health system, you should be thinking, where is the bottleneck going to be? So if you think about having more patients who are sick than you ever had ever before, all at once, what are you going to run out of first, second, and third, and how can you mitigate that? Space is, of course, at a premium right now here in Nova Scotia and certainly across the country as well. And where can you expand your clinical space when you have a surge of patients? Do you have adjacent annexes near your ED? Do you have non-clinical spaces that can be converted quickly if needed? And how can you overflow your ICU into the PACU and so on? And then support is knowing who can help you and from where, and having that all set up. And certainly having a way of command and control is really critical when you get into responses that are taking longer than a single shift at the hospital. So when we look at command and control, the incident management or incident command system is the preferred system globally. This is a civilian system that was developed in the 1970s in California for fighting wildfires, so there'd be a bit more coordination between various county responses. And it's made its way into disaster medicine over the years. ICS is, I think, honestly a fantastic resource, and I think anyone who works in healthcare should at least have the ICS 100 course completed. It takes a couple of hours. It can be accessed through FEMA, I believe, for free. So you should certainly look up ICS if you haven't yet been certified, just so you can understand at least the language that's being used. What's on the screen here is the sample incident command hierarchy, so to speak, when you're looking at a single hospital response to a mass casualty event. So you'll have one person who's the incident commander. This will often be the senior administrative lead that you have on site. They'll have a public information officer whose job is to deal with media. It's important during any major event like this that you have a single voice that's communicating with media, with families, so that people are not getting mixed messages. And certainly what you don't want is people just telling what they saw or maybe saw, because that's going to lead to a lot of confusion. The most important person For the response, it's your operations section chief. This person would ideally be the most experienced charge nurse that you have in your department. Speaking as an emergency department, that person tends to have a very good knowledge of the operations of the department, has their finger on the pulse of the department all the time, and would be able to then direct your actual operation units to deal with the clinical response. So in this case, we have a reception branch, which is triage and registration. Very important to make sure that you know who your patients are as they move through the system. And until they get registered, it's really hard to get any diagnostics done. Then, of course, the treatment branch. And in this case, it's been divided into a priority 3 or green walking wounded zone, an expectant zone for people that are not going to survive so they can be palliated correctly. And then your priority 1 and 2 zone with resus teams attached to it. So this is an example. The benefit of ICS is that it's extremely scalable, and it can go from a response of 5 people in an ICS structure all the way to a response of 10,000 people. So it's very scalable, and everyone should know about it when we're talking about disaster medicine and mass casualty events. And so before we get into triage and treatment, we need to talk about the care continuum. So often we like to be in the conventional side of the care continuum, far on the left. And this is where everything is running as it should be. And this is where I think we live most of the time in our own minds, that we want to offer the standard of care to every patient we see. And that can mean really sort of pushing the envelope as far as resuscitation goes and doing all we can if there's a reasonable chance of a good outcome. So under a conventional system, we're talking about Reboa, we're talking about ECMO, I mean, all sorts of things. We're really pushing it, trying to keep people alive. When we start moving into contingency, the level of care can be functionally equivalent, but may be delayed. And you're going to have to start conserving supplies, staff are going to be taking longer shifts, and you might start having to use clinical spaces that are not normally used for those particular patients, but they're still clinical spaces. When you get to the far right of this continuum, you get into crisis care, and that's when the wheels have fallen off the bus. When you are in crisis care, you're really triaging your ventilators. You're triaging who's actually going to get life-saving care, because you may not have enough of everything. You may be almost out of blood products, you might be out of chest tubes, you might be out of sterile OR equipment, you'll certainly be out of beds. Patients are going to be finding themselves in hallway cots, maybe cafeteria tables. So crisis care is really what we all fear having to work in, because I think for all of us, we're always trying to honestly, help our patients in the best way we can. And when you reach a crisis, philosophically, that becomes very challenging. And it can be very uncomfortable to even do thought experiments, thinking about how you would be able to provide any level of reasonable care in that situation. And we're going to talk about this continuum as we go forward and how we can do empiric resuscitation on patients. But before the patients arrive, we have to triage them. So we're going to be talking about triage systems, both for first responders and first receivers. So field triage has been around for a very long time. For the history nerds in the audience, it started in the Napoleonic Wars, at least first recorded then, with triage being from the verb trier in French, to sort. And this has really evolved over the years. And right now, the start or jumpstart triage sleeves are the most widely used in North America, with SALT being kind of the runner-up. So the differences between those two are very, very limited. The literature on it is not great because they really can't study actual events. So these are usually simulated events, looking at either physicians, nurses, paramedics, and getting them to triage certain simulated patients, and they look at accuracy with over or under triaging, and then differences in time. It's not huge differences. So we're talking about seconds of difference and very slight decreases in under triage between the two. And both START and SALT have physiological measurements that are used in the triage sieve. And so 10-second triage, which is a newer triage sieve coming out of the UK, does not use any physiological measurements, which allows it to be a little more accurate as far as under or over triaging, and also takes less time. So let's get into those. So first, this is START. Many of you may be familiar with START triage. It's the classic 32 can-do mnemonic for figuring out where patients fall. Essentially, anyone who can walk is automatically minor. It's assumed that anyone who's able to stand and walk around has the circulation and respiration required to do so, and thus would be delayed response. People who are not breathing are dead if they don't breathe after opening up their airway. If people are breathing, but they're not conscious or not being able to follow commands, if their perfusion is bad, so no radial pulse or a capillary refill of greater than 2 seconds, or they're breathing over 30 a minute for adults, for children it's less than 15 or over 45, then those would count as immediate or priority 1, and everybody else is priority 2. So this works well. You can get rid of all the people who are walking pretty quickly. Respiration rates, not always the most reliable thing to measure. And certainly trying to get a radial pulse on somebody outside in the cold who's peripherally shut down is very challenging. Similarly, getting cap refill when there's clothing, burnt skin, blood may be tricky. I mean, even thinking about being in a resuscitation bay in a fairly controlled environment, when you ask people to feel for a pulse, it usually takes more than one person. It certainly takes a few seconds for people to agree on what they're palpating. So doing this in the field can have some errors prone to it. SALT is sort of the second most common triage tool, and it has a similar pathway, but what SALT prioritizes is immediate treatment by the first responders. So first you sort, and again, walking is assessed third. If people are waving but can't walk, you assess them second, and if people are doing nothing, you assess them first. During your assessment, you're going to open the airway. If it's a child, you'll give 2 rescue breaths, which is in line with the jump start sieve as well. You're going to control major hemorrhages with pressure bandages or tourniquets. You will decompress the chest, and SALT was initially derived for military use, and they would inject the auto-injector antidotes for nerve gas if applicable. If once you've done those life-saving interventions, the patient is not breathing, they are expectant or deceased. If they are breathing, then you'll see that there's really a very similar sieve here to START, which is, can they follow commands? Do they have a pulse? Are they not in respiratory distress? And is the bleeding controlled? And if yes, then they're either delayed or priority 3 if they have minimal injuries, and otherwise they're immediate unless, and you see the key there is, are they likely to survive given current resources? So we're kind of bridging into secondary triage with SALT. Again, though, SALT does have an assessment of peripheral pulses, which can be challenging pre-hospitally. So that gets us to 10-second triage, which I think is probably the most simple of all 3 and does not have any physiological measurements that are required. So you can do this almost just looking at the patient from several feet away. So are they walking? If yes, priority 3. If they're not walking, if they have severe bleeding, they're priority 1. You treat it and they're still priority 1 because they have an injury that was bad enough to cause the severe bleeding. If they're not severely bleeding, are they talking? If yes, do they have a penetrating injury that is proximal? And if they do, they're priority 1. So 10-second triage is really looking at mass penetrating trauma, generally speaking. So people that maybe have a gunshot wound to their lower leg, not so bad, priority 2. But if it's proximal, we need to assume that that bullet or that fragment of a bomb or something has gone somewhere that could be potentially life-threatening. And unfortunately, looking at where an entrance wound is on the body is not super helpful in being able to rule in or rule out the pathway of the bullet hitting something that could be potentially life-threatening. So any proximal penetrating injury is immediately P1 in 10-second triage, which is a feature that I really like. And then moving down, back to the same thing from from SALT and START, which is, are they breathing, yes or no? And if not, then they would be put as expectant. So that's all pre-hospital triage. When patients arrive to the hospital, they'll usually be re-triaged. At the QE2, we use START triage when patients arrive to re-triage them in case anything has changed from the pre-hospital assessment to when they arrive. But there's also something called SAVE triage, which is a secondary assessment of victim endpoint. And that breaks patients down into these three categories. Either they will live regardless of what you do, and live does not mean live without disability. It means survive only. So somebody with very bad ocular injuries or an amputated hand, they'll live, but they'll have disability. At the bottom, you'll see people who will die regardless of treatment. So people with high velocity gunshot wounds to the heart, people with exposed brain matter, people with 80% body surface area burns who are 73 years old. These people will likely die regardless of what you do. And so both of those categories do not require aggressive therapy. So people that will live regardless of what you do, let them live and get to them later to deal with the disability. And people who will die regardless of what you do may not be worth the dwindling supplies you have, unfortunately. So the key group within the secondary assessment is who are the people who will survive if we aggressively treat them. And that's where you need to start putting your resources. And that gets back to that continuum of care. So when you start reaching contingency, and certainly when you're in crisis level of care, it's that middle group of patients that you need to be looking for, because they're the ones that need to eat up your blood supplies, and those are the people that need to get into surgery first. Now, there is no official sort of SAVE triage sieve, and it really depends on your own hospital, your own specialist, your own ethics board, and how you would derive this. This is an example of a SAVE criteria that looks at burns, head injuries, and crush injuries, but this is not an official guideline to be used, but it just gives you an idea of how this works. So, for example, with burns, you're looking for people that have a greater than 50% chance of survival. And if they have a less than 50% chance, you put them at the likely will die without intervention. Examples of this would be people with 70% full thickness burns, people over the age of 60 with inhalational injuries, less than 2 with greater than 50%, more than 60 with 35%. And speaking with our burn surgeon colleague would be interesting. Again, this is an example based on One Health System's facilities and what they actually have to offer. And so it will change depending on where you are. But these are the types of things you need to think about when you're looking at doing secondary assessment triage. With the head injury, if their GCS is less than 7 from their injuries, it would be assumed they're not going to have a good outcome. And again, this is looking at when you're stumbling into that crisis care and you may not have a lot of ventilators, you may not have a lot of resources to even bag these patients. And then with crush injuries, it's just saying essentially, depending on how severe it is, you either amputate it or you could try to save it. There's a cutoff of when you're going to spend those resources to do that. So that would be triage. And now we're going to get into hospital reception. We're going to talk a little bit about previous sort of documented patient presentation epidemiology, as well as what to do with these patients once they arrive. So literature from mass casualty events would suggest that once you reach the peak of your patient surge, you'll be getting about a patient every 30 to 60 seconds. That said, in mass casualty events, the average time to transport by EMS is around an hour. That said, you're also going to get lots of people who do not come via EMS because the resources may not be there and they may be able to self-transport. So people may walk to a hospital if it's close enough. They may self-transport either being thrown in the back of a truck by an unwounded friend, or taking an Uber, right? People can find their way to care in many different ways. The people who arrive first are often not the sickest patients because they're able to get to the hospital under their own strength. That said, patients brought in by police or by other civilians in their own vehicles may still be very sick. So it's hard to say, but once you start getting into the real crunch of the surge, you're going to be getting a lot of patients within a very short period of time. For the purposes of this talk, we're talking about penetrating trauma and fairly high velocity penetrating trauma. So we're talking about civilian public mass shootings, which are the sort of scariest and unfortunately increasingly common presentations, certainly in the United States, but Canada and Nova Scotia are not without this experience. And I think it is something that may become more problematic here in Canada as time passes. Historically, these types of events would have about 5 injured people for every single person who is dead on scene. That said, more recent 21st century civilian public mass shootings have had extremely high case fatality rates. So if you see on the left, there's a number of the sort of more well-known American mass shootings alongside the American experiences in several different wars, including World War II, the Vietnam War, the entire Afghanistan conflict, and the Iraq conflict in 2003. And you can see that in wars between nations, the case fatality rate for gunshot wounds is actually pretty low. It's at most 1 in 5. Whereas you can see that for the civilian ones, the lowest is 13%, and most are 50% or more. And a lot of people find that very strange, but when you think about it, it actually makes, unfortunately, a lot of gruesome sense in that in military conflicts, engagement distances are often fairly far, sort of 100 to 500 yards. Combatants are usually in cover or wearing armor or both. And there's usually immediate first aid available, at least as far as tourniquets and some other immediate first aid things, whereas for civilians, they don't have any of those luxuries. So usually civilian shootings are extremely close range. There's no protection, there's no cover. And even the perpetrators are different. So in military conflict, soldiers tend to shoot towards the enemy, not at them in the same way that mass murderers do. So there's a lot of different factors as to why the civilian things are much worse. And looking at reviews of dozens of these events, we can see that when we're looking at non-fatal injuries in civilian mass shootings, the vast majority are all extremity, which makes sense. Any injuries to the chest, abdominal, pelvic region, or head or neck are often fatal in these situations. So if you're dealing with a mass casualty incident, you're going to be seeing a lot of extremity injuries that make it to the hospital. Disposition of patients from those studies tend to almost be evenly distributed between surgery, ward care, ICU, and being discharged. And the discharged patients are usually those with minor extremity injuries. So for the less injured people, the walking wounded, perhaps limping wounded, but still under their own strength, you're going to need space, staff, and supplies. So getting back to those critical substrates. You're going to want to consider having an ED adjacent annex for a couple of reasons. First, you're going to need the space because you could conceivably have dozens of patients coming in that will not fit into your already overburdened ED. Second, you're going to want to separate patients with more manageable injuries from the critically ill so that those who are responding to critically ill patients don't have a crowd of people sort of thundering in and trying to get care or get the attention of those providers. So you need to make this part of your Code Orange plan. It would also be very wise to have dedicated supplies for this annex so that if you get a call in from your pre-hospital colleague saying, we have a mass casualty incident, we have dozens of casualties, and some of them are already on the way to the hospital under their own strength, you can call your code orange and you can move that dedicated supply cart to the designated ED annex and set up a treatment area, a treatment zone for those patients. So when they arrive, they can be quickly moved over to the providers there. At the QE2, we've put together a 50 casualty supply cart, and that's checked for perishable things every 3 months to be put back into regular circulation. As an example, this includes a number of sterile trays, lots of gauze, pressure bandages, tourniquets. There's some chest tubes and Pleurovax, and then simple analgesics, so Tylenol, Advil. So you can get that all out, and then IV starts and crystalloid. When we're talking about these sick patients, those who do not have minor extremity injuries but have those proximal penetrating gunshot wounds or stab wounds, this study looked at folks who did die and looked at what wounds could have been non-fatal if action was taken immediately. So most injuries, again, are going to be looking at extremity injuries. Just about half were extremity injuries in this particular study. And we look at fatal wounds, the larger amounts there are the chest and upper back, obviously, and then the head. So those make up a large amount of fatal wounds, certainly more than the amount of numerical injuries. That said, for wounds that could have been prevented from being fatal, the biggest bang for your buck is going to be obviously extremity wounds, people bleeding out from sort of proximal extremity wounds. But when it comes to the chest and upper back, the key there is lung parenchymal injuries. So those are injuries that can cause death, but could have been preventable. And in this particular series, it was about 12 to 13% of the lung injuries could have been non-fatal if intervened. So about 1 in 8, which is not bad. And we do certainly more resuscitative things on people that have a far lower chance of surviving. So this gets us to empiric resuscitation. How do you deal with many casualties with unclear wound patterns and limited personnel, limited supplies? And is there a standard procedure to resuscitate the blind penetrating trauma? And what I mean by blind penetrating trauma is that as soon as you have certainly a bullet in your abdomen or your chest, you don't know where it went. And you can guess, but you'll never really know. Once a bullet enters soft tissue, it can bounce off bones, and it can kind of start to yaw and move in a non-straight line. So that's one problem. The other problem is that high velocity bullets will cause a pressure wave to go through soft tissue and can cause a lot of vascular damage, not necessarily where the bullet went, but in adjacent areas. So as much as we would like to CSI these patients in our mind and try to think, okay, there's the entry wound, what organ did it hit? Until you can get definitive imaging or a laparotomy to see what's going on, you really won't know. So that's what I mean by the blind penetrating trauma. So in these cases, we have a lot of people, we need to fix a lot of people, and we don't really know up front what the injuries are. And it would turn out that there really is not a standard procedure for this that I could find in the literature. I did have a great opportunity to speak with the medical director for the Canadian Special Forces, Dr. Ballet, and she and I had a great conversation about this, and she pointed me to some of their algorithms, especially for sort of remote trauma resuscitation, which is the closest thing I could find to the non-remote area, but with lack of supplies and lack of staff. So when you're kind of dealing with crisis level care, what can you do? And what it boils down to is essentially this. So you're going to pack or tourniquet any massive hemorrhaging that you can see. You're going to open the airway of the patient. You will decompress the chest bilaterally to alleviate any possible tension pneumothoraces. You're going to get IV access, and then you're going to give them blood and calcium, tranexamic acid, fibrinogen, and antibiotics. And those things together kind of comprise the empiric resuscitation of a blind proximal penetrating trauma. For antimicrobial coverage, the Canadian Special Forces actually use ertapenem as their standard, and that's to cover for bugs with the understanding that they're dealing with dirty environments. So guys that have been in the bush or in the dirt for weeks and then have a penetrating trauma that's going to draw some of that contaminated clothing into the wound. The other benefit to it is that it's daily. So you can give that one dose of 1 gram of ertapenem, IV, IO, or IM if you don't have access, once a day, and you can call it there. You don't need to reassess that patient for antimicrobial coverage. And that's a really big benefit if you're dealing with mass casualty, because you can give an IM shot and just say, yep, they have their antimicrobial coverage, and you can move on to your next patient. That's very helpful if people are shut down and don't have good vascular access. Now, ceftriaxone would be a reasonable alternative to that, I think, in our context, and similarly is going to be a Q24-hour medication. For pain management, anyone who's walking and talking with moderate pain, they would give Tylenol and meloxicam to. And, I haven't given a lot of meloxicam, but the rationale there is there's no antiplatelet effect, and it is recommended as per TCCC guidelines. So that actually made a lot of sense to me. And then for severe pain, they do provide fentanyl lozenges to soldiers in the field. Within the civilian context, we don't really have access to those. And I think based on what we have, ketamine is a really great option as well. And so the Canadian Forces uses ketamine either every 20 or 30 minutes IV or IM with set doses. So again, having an IM option for pain control in a sort of shocky patient is great, and it is a fire and forget. You just give that IM depot and you can walk away for 30 minutes knowing that you've given them something. So again, this is not conventional care. This is bridging into crisis care where you may not have the staff to be sitting on patients as much as we would normally do in standard of care. So things that all penetrating trauma patients need: they need ATLS, they need their primary and secondary surveys. They're going to need POCUS. In crisis care, your formal radiographs will be extremely limited. There's not that many portable X-ray machines. There are not that many radiation technologists to do those. So I wouldn't expect that those are going to be available for all your patients right away. So practice your POCUS and know how to do your EFAS. Fluid resuscitation, ideally with whole blood if available, or 1:1:1 with calcium given. And we'll get into some issues with blood as we progress. Tranexamic acid, 2 grams of the bolus, and then forget about it. That's shown to be non-inferior than the 1 gram up front and then a 2nd gram as a drip. And it leaves you with more IV space for other things. And again, you don't need to monitor that. So when you're dealing with a lot of patients, give them 2 grams, walk away. You're done that part of their resuscitation. Antibiotics, ceftriaxone or ertapenem, put it in and you're good for the day. And extremity hemostasis. Things that sick penetrating trauma patients need, that's that blind proximal penetrating traumas, bilateral thoracostomy holes, fingers or tubes. If you can get a tube in there, obviously better long term. Pelvic binders to limit space in the pelvis, depends, and I can speak to that later. It really depends on the mechanism, but sometimes you don't know exactly what the mechanism was. And so if there's any suspicion that there could be pelvic injury, you can always take the binder off. Massive transfusion protocol, immediate OR triage to see who needs to go up first. And if you have the staff and the stuff, you may need to assist their ventilation now that there are holes in their chest. So what does that mean in practice? Open their airway. If they're not breathing, they're dead. If they are breathing, stop all the bleeding you can see. Provide analgesia, tranexamic acid, antibiotics, plus or minus fibrinogen, and we'll get to the specifics of fibrinogen in a moment. And if they have any proximal penetrating trauma, you're going to decompress their chest, do your save triage, and then if that's someone that you can save, provide your blood products and get into surgical triage. Speaking of blood products, there are sort of some problems with giving a lot of blood products to a lot of really sick patients all at once. Within the Halifax context, I have some data from 2020 looking at massive transfusion protocols, and the ratio is not 1 to 1 to 1. It's about 1 to 1 to 2.5. And I spoke with the doctor who's in charge of the blood bank here at the QE2, and he told me it's really about 1 to 1 to 3 on a good day as far as what they can provide. And the bottlenecks on the blood bank side are the availability of platelets. There are not that many at any given time, and plasma, in that there are only a certain number of plasma warmers to actually warm up that frozen plasma, and that's a major rate limiting step. So this is what the QE2 blood bank had as of about 2 weeks ago on the 9th of June. So you've got some O negative, most of it at the infirmary, some at the Victoria General. We've got a lot of O positive kicking around, so that's good, about 50 units. Some various other more typed blood. And then if you look at the amount of platelets, there's only 11 packs. And fresh frozen plasma, as I said, doesn't really matter. So every hour they can warm up 2 units of platelets, or of plasma, I should say. There are 2 warmers. That is not great. So if you're trying to get 1 to 1 to 1, unless you're transfusing that 1 to 1 to 1 very slowly, the plasma is not really going to catch up, and you're going to run out of platelets fairly quickly. So what you can do is give the factors that you're trying to give from the fresh frozen plasma by other means. So PCC and fibrinogen are shelf-stable supplies. So they're not frozen, they're not refrigerated, they just exist, and you can give them. And there's about 25 doses of fibrinogen and 11 doses of PCC within the Halifax QE2 sites at any given time. So you have a little bit of room to maneuver, and if you had 10 really sick patients, they could all get around 5 to 6 units of red cells, a pack of platelets, 1 dose of PCC, and about 2 doses of fibrinogen of 4 grams. So that gives you some ability to help any coagulopathy, but again, not great. Now that's what's available immediately. Within several hours, the giant CBS storage site over in Dartmouth can mobilize more product and get them to the hospitals that are receiving these casualties. So when you're thinking about your code orange response, getting in touch with blood bank is going to be important to let them know you're going to have many massive transfusions going, and they'll take it from there. So they'll talk to CBS in Dartmouth, and once the units start being used, they're going to be brought over. But important to let them know so they can start that process. And always remember to give calcium. So hypocalcemia due to the citrate in packed cells further exacerbates the rest of your lethal triad. So you're going to be wanting to give calcium gluconate, calcium chloride, pretty much with each unit of blood you're giving. So empiric resuscitation summary. Your maneuvers: open the airways, apply tourniquets, pack wounds, bind pelvis, decompress chest. And then your empiric resuscitation drugs: fibrinogen, ketamine for pain control, tranexamic acid, PCC, antibiotics, calcium gluconate, and the blood that you have for that particular patient. So putting it all together, on the left side, you have your triage. You're gonna have to do that pre-hospitally upon hospital reception of mass casualties. You're gonna have to do your save triage to determine endpoints for the victims and their survivability, to know who should be getting those critical blood products, and then surgical triage is going to have to be done by our surgical colleagues as far as who they think they can fix and who goes up first. On the right side, you've got your empiric resuscitation for your sick patients, and then you have your walking wounded annex for your not so sick patients. And in the middle, the care continuum, the philosophy of what you can provide to patients, command and control through ICS, and just remembering that we're all working as a team in a very chaotic, horrific environment. And you're just trying to bring a little bit of order to what would be complete chaos. I would love to see if you have any questions, and hopefully we can have a bit of a discussion.
Dr. Armstrong, thank you so much. It's Adam Harris there. Just while people type questions into their chat, I want to thank you for doing all the work looking at what blood products we have available right now. One of the questions I had is certainly around blood product utilization in a resource limited situation such as a disaster. You talked about the current Halifax scenario. In the regional facilities, most have somewhere between 2 to 4 units of packed red blood cells and no platelets and no FFP. So, you know, if a mass casualty event was to happen in a more remote or rural or regional facility in our province, what are some kind of additional considerations that you would think about in that scenario, i.e., you know, patients that are triaged to be treated definitively there in the operating room, ICU, versus, you know, what patients you look at moving out to the trauma center, kind of what that looks like? Just kind of wanted to get your thoughts on that.
Yeah, that's a really good question. I mean, if you're limited, you only have 4 units of red cells and nothing else. I mean, your response is going to be extremely limited. I guess prioritizing stopping any bleeding you can see becomes even more important. Being able to communicate with sort of your regional and then your trauma centers, as well as your critical care transport teams, is kind of going to be paramount. And the way that can work now is, you know, a physician in a rural area can phone in to Life Flight or to the medical comm center and can actually get on the phone with charge physicians at other centers, the Life Flight doc, the MCC physician, and try to coordinate how to best move those patients. At the end of the day, penetrating trauma is a surgical disease. And so you can provide blood products as a stopgap to buy those patients time to get to an OR. But inevitably, that is what they need. I suppose another thing to think about would be what regional surgical capacity is there? And that brings me back to the continuum of care. So there may be a lot of very talented surgeons that work in the community who are not trauma surgeons, but they're still surgeons. And so if you're looking at, you know, a catastrophic event, surgical definitive care may mean damage control surgery to stop internal bleeding with packing before you can move them to definitive care. But certainly in the ED, we can't do that. So the regional or rural surgeons may need to do things that they haven't done in a long time or maybe uncomfortable doing. And that's a conversation that needs to happen before you reach an event like this. I don't know if that answered your question. But
oh yeah, no, that's exactly what I was thinking about, you know, in terms of, you know, you may have access to 2 or 3 general surgeons, but you also may have, you know, 3 obstetrician gynecologists and a couple urologists and others that, you know, certainly if called upon and if the location knows to call them, would be able to help in this type of situation for sure.
Mm-hmm.
In terms of surgical.
I think our surgical colleague could speak to that far more than I could. So hopefully they can chime in.
Yeah, that's great. Thanks, John.
There's another question. Any apps you recommend to use on smartphones, John, for a quick reference guide for colleagues?
A quick reference guide for?
I'm assuming disaster management?
Oh, you know, I don't have any myself that I'd use. There were some good ones for chemical and radiation things, but they've been discontinued by the US government. so they're no longer available. Those were things like Wiser. But as far as an app for mass casualties, I don't use one myself, so I couldn't comment.
Yeah, that was from Dr. Travers. One that I've come about just recently, it's called Deployed Medicine. It's free. Haven't worked through the whole app yet, but it might be one that Dr. Travers could be
Dr.
interested.
Travers loves a good app.
Yeah, Deployed Medicine. Deployed Medicine.
I don't see, oh, Deployed Medicine. I don't see any other questions. So I guess, John, if you don't have any other final statements or any, oh.
Yeah, I guess one thing I'll ask a question to myself because I have a slide on it. The idea of using pelvic binders and penetrating trauma is contentious. Many people would say it does nothing, and they would be correct in many cases. So I did do a little literature review on civilian gunshot trauma and whether or not there's any benefit to pelvic binding, and the answer is generally not, unless there's high velocity rifle cartridges being used. So it seems that no small arms that are sort of pistol caliber will actually do anything to your pelvic bones that would require a binder for an unstable pelvis. That said, high energy rifle rounds can completely obliterate your pelvic bones and cause an unstable fracture essentially. So again, if you're not sure exactly what the mechanism was, you can always take a binder off. And that's what I would sort of conclude with from that point of view.
All right, we don't have any other questions, so I guess we'll wrap this up for today. Thank you very much, John. That was a wonderful presentation.
Okay, thanks so much.